Okay. It's my pleasure to welcome you all today to our day entitled Strength and Resiliency, Tools for Individuals Living with OCD and Their Families. Many of you know me. For those who don't, my name is Dr. Peggy Richter, and I'm a staff psychiatrist here at Sunnybrook and heading up the Frederick W. Thompson Anxiety Disorders Center. And it is really a pleasure to see this kind of crowd out here on a Sunday. We've been doing a lot of things since the Thompson Center opened its doors 5 and a bit years ago, but this is actually our first venture into doing a day oriented at individuals and families. We've done evenings, we've done shorter sessions, but this is new. So welcome to all of you, and thank you to all of you for helping make it such a success. I thought I'd start by just telling you a little bit about our program, because could I see a show of hands actually? How many have already had themselves service through a program or have family members or loved ones who are being served through our program? So that's really interesting, because there's quite a few people then here who do not yet have service through our program. So I think I will just tell you a little bit about us. The Thompson Center came into being just a little over 5.5 years ago, and that was through the generosity of Frederick W. Thompson. Fred was a bit of a visionary, and he wanted to make a difference more than anything else. So when he was thinking about where he could make a sizable donation, it was really interesting. He had a family with healthcare connections, but he decided mental health within healthcare was where it was needed most. And it was really his vision that I share and that we've brought to fruition. And our goal has been to launch a center that really offers people state-of-the-art clinical care, really excellent education for individuals and for mental health professionals around OCD and related disorders, research that can make a difference in people's lives, and advocacy for people affected by these conditions. And I think I can say with some pride that I think we've done a pretty good job of beginning to accomplish those rather impressive sounding goals. There's still room for improvement, of course, but I think we've done really well for a new program. So our program has actually retooled a little bit in the last 1.5 years. For those of you who may have had contact with us earlier, when we initially launched, we were trying to do everything, and we were quickly overrun and realized we just couldn't meet those needs. And so our focus now in terms of healthcare provision of service directly is really targeting the needs of those with the most severe illness. And the reason for that is straightforward. Difficult though it is for all the many people out there with OCD who are starting out on their journey towards recovery, the situation is dire and worse for those who find first-line treatments don't work, who've not been able to find services, or whose illness is particularly severe. And so, again, acknowledging that we can't do it all, I think this was a good decision. And as part of that direction shift, we've been able to, in this past year, launch an intensive treatment program for OCD, which is the first in Canada, one of about a dozen available internationally now, headed by some of my wonderful team up here on the podium who I'll be introducing. And we're also beginning to work very closely with the new Hartwell Center for Neuromodulation that's just been announced at Sunnybrook, through which we will be able to offer, and are already beginning to offer, cutting-edge biological treatments for those with extremely severe and refractory illness. So it's an exciting time for us, and there's a lot that we have on the go. Maybe before I tell you a bit more about our center, I'm going to just do some brief housekeeping announcements. So we've had outstanding interest today, and that is both a great thing and a sad thing, because there are many people who couldn't be here today to share it with us personally because we had run out of space. So I know there's about 50 people or more tuning in for our webinar, and I want to welcome all of you who might be watching us from your homes right now. We also have about 60 additional people in the neighboring lecture hall, because this room was already full, and I want to welcome them as well. And I'm just sorry that we couldn't find a space big enough to accommodate the 250 or so that were expressing interest as of Thursday or so. So my numbers might even be a little bit low. There are more seats in the adjoining auditorium for those of you who are stuck. There may be a few more seats also in the room. I see a few seats over here, like 1 or 2 per table. You may not be able to sit together, a few there. So for people who do want to wander in, there are seats here, and otherwise there's lots of room in the other hall. Washrooms are around the bend towards the stairs on the left. Parking is unfortunately not free. I know that some of you have asked, and I do apologize that the hospital charges a fairly hefty amount. I do want to assure you, the one good note out of the parking costs is that the money does come back to support the many wonderful programs at Sunnybrook, including things like our speaker series, through which we offer events open to the public on OCD and related disorders at least once or twice a year. For the webinar registrants, I want to mention that the chat functions are not functional, so you can't just hit chat if you're watching us now via Zoom, but you can send emails, and I'm going to show you that email address in a moment, but it's essentially what it sounds like, which is Thompson Center Education, all one word, at sunnybrook.ca. Again, that's Thompson Center Education, one word. I'll put it together as one word, at sunnybrook.ca, and I'll be showing that. So if you have questions, you can send them to us that way. We cannot promise to answer them in real time today, but we will be circulating frequently asked questions response afterwards. So those of you who don't get questions answered, we will do our best to try and give responses after the fact if we can't get them all today. I hope you all find materials on the table. There are some schedules, I think some materials for our keynote speaker, Dr. Breacher, who you'll be hearing more about shortly. We also have some Hyatt Hotel notepads, I think, for notes. This is not the Hyatt, but they've been kind enough to share notepads with us, so maybe enough about that. Some of you may have, I'm sure most of you have smartphones. I would request that people be sensitive to people's wish for privacy, and please do not take pictures or tape in the room. That would be disrespectful of many people here, so we ask you please to respect that. There are evaluation forms on colored sheets on the tables, and I would make a strong plea that you fill them out. I have to say, in my experience, crowds of families and loved ones do a lot better than healthcare professionals, where I usually have to request it 3 times, and sometimes I've almost held people hostage on their way out of the room. But we really would appreciate your feedback. This is the first time we're trying to do a half day like this, and your feedback is what will help us make it better if there are things we can improve or tailor it more to the needs of the community. And I think that's about it. I was just going to briefly tell people a little bit about our program. And just to kind of make people aware, then I've already touched on this. So in terms of the services we currently offer, we do have a consultation service that is open to anyone across Ontario. However, our focus there, again, as I mentioned before, is away from people first seeking help for OCD, who we would encourage to seek help locally, but towards individuals who have more severe illness and who have failed a few first-line treatments. The reason, again, being that that kind of expertise is hopefully out in communities, and I'm going to show you a slide in a minute about an initiative that may help with that further, and we want to be available within a reasonably short time frame to those who really need us. We also offer a specialized service for very severe OCD, which includes consultation and potentially an episode of care. And again, that is not geographically restricted. For those who may live right around the geographic area that Sunnybrook is in, we do offer a broader range of services, and I apologize that that's no longer open across the entire city. It's open as our capacity allows, because unfortunately, generous though Fred's gift was, we're going to run out in about 4 more years, and we are hoping our center will be around sustainably, but we just can't do more with it right now. We do offer other biological treatments increasingly, which I mentioned, through our modulation program in partnership with the Hartwell Neuromodulation program, and our intensive treatment program. And for those of you with interest, there are brochures outside on the tables. Which reminds me, I want to say thank you to the tables out there. We do have tables set up for a number of things. I think there are materials on a project we're running showing the Muse device, which is a private and commercial device, but we are looking at it in a study here to see whether it helps people develop mindfulness skills on their own. We're also trying to do a study to better describe the costs of OCD in terms of what is available to people through public health care and what is not. Can I see a show of hands? How many here have had to access services privately or have thought about it? Right. This is a problem, and we recognize it. So if any of you have a loved one here with OCD today who'd be interested in helping out, this is a research project. It is completely confidential, but our hope is that these statistics will help us in advocating with the government over the next few years with the launch of more funding for brief psychotherapies to make the case that some of that needs to go to OCD. So please do think about participating in that. We also have, I think, some materials from Toronto West OCD. I know Christine is here from them, and she'll be at the table, and other materials that may be of interest. Okay. For those who haven't seen our website, I think this is now an actually slightly out-of-date image. I keep forgetting to update regularly enough, but I wanted to just draw attention to our website, which you can find at sunnybrook.ca/Thompson Center. We come up after Thompson Firearms. Don't ask me to explain that one, please, okay? No connection to us, but we're usually about the third hit if you just Google Thompson Center. But what we have on our website, just so that you know, is a copy of our patient handbook. It's being sold outside for $5 for a very pretty glossy printed copy. However, it's also available free to download to anybody from our website. And there are other resources up there for clients and for mental health professionals. We have other educational events coming up. So we have an event in June on hoarding that will be open to healthcare professionals and people with lived experience. And if you visit our website regularly or link to my Twitter account, which is not nearly active enough, we will be trying to send out little announcements ahead of time through Twitter so people can find out about events like this a little bit earlier. And last, for those of you who have healthcare professionals who have expressed to you interest in learning more about OCD, I think there will be some flyers photocopied out there to tell people about a new project which is aimed only at healthcare professionals. But our goal with this is to reach healthcare professionals across the province to give them a distance learning opportunity to learn more about OCD with our team. So that may be something worth mentioning. Okay, for questions, there is the address again, and now I'm delighted to introduce Sandra Cushing. Sandra Cushing was a social worker who joined our team about 8 months ago with the launch of our program here. Sandra brings to us about 25 years experience in mental health as a social worker, working in mental health and addictions broadly across a range of topics. She's been instrumental in helping us launch our new program at Bellwood, where we're based physically, and is also going to be launching family initiatives for our outpatient services shortly. Sandra, thank you.
Thank you, Dr. Richter.
It's just kind of that one. Yeah, there we go.
Okay, great. So lovely to see so many people here today. As Dr. Richter mentioned, I'm a social worker with our intensive treatment program. So my focus today is really to talk about how OCD is very much a family matter. Even when I speak about families, I mean biological family, but also friends and key supports in the lives of an individual with OCD. I'll provide a brief overview of OCD. We had a morning session with individuals in our program and their family members, so there might be a slight bit of repetition for those individuals, but I'll keep this part more brief. We can always make the slides available just so that you have more time to talk about the impact of OCD in family members. So what is OCD? OCD is this disorder of tremendous internal discomfort with strong obsessive thoughts and these urges to do these rituals to sort of reduce the distress of the thoughts. It's the fourth most common psychiatric disorder and it's the 10th leading cause of disability worldwide. And about roughly 2% of the population have OCD, although we're recognizing that many people who might have like anxiety or other mental health presentations might have some components of OCD as well. To receive the Diagnostic and Statistical Manual, version 5, helps us to define what OCD is. But to receive a diagnosis, you meet the general criteria of having obsessions, both obsessions and compulsions, and I'll talk about examples of both in a moment. And they have to significantly impact your life. They're consuming at least an hour a day and often several hours a day. Some people, it's all day long, even in their dreams, when they're experiencing impacts of their obsessions and compulsions. So I mentioned this lifetime prevalence is about 2 to 3%. Age of onset, we see onset often in mid-teens to early 20s, but certainly there's children with OCD presentations very early on. And there's high comorbidity in terms of depression, anxiety, and having OCD in parallel with that, along with other OCD spectrum conditions like body dysmorphic disorder. And in terms of lifelong, it's this sort of chronic illness, and it can wax and wane, but many people, it's not something that usually is resolved and it never shows up again. It can show up at different points in a person's life, and it may get better for periods, it may come back. And so in our treatment program, we really work on helping people to learn the skills and the tools so that if it does reappear or get worse for periods of time, they know how to manage and they know how to work with that. These are just some studies that talk about remission. So 20% back in a study in 1999. I think the remission rates are 20% remission rate after 40 years. Another study showed 24% partial remission of symptoms after 2 years. And with the pediatric population of OCD, 41% still having OCD fairly significantly after 5 years. So just breaking it down a little bit more, so these persistent unwanted thoughts, and that's the distinction in OCD. People don't usually, their obsessions aren't about financial worries or relationship concerns. They're these persistent unwanted thoughts and or images or impulses that are uncontrollable, that are showing up all the time. And many of the general population have these same thoughts, but with an individual with OCD, they become sticky thoughts and they really latch on, and they're not able to let go of those thoughts the way that other individuals would. And I'll show an example of some of those thoughts in a moment. The compulsions are the repetitive behaviors or mental acts that someone does in response to that obsessive thought to try to neutralize or reduce the distress that's affiliated with it. The symptoms must cause marked distress, and like I was saying earlier, often several people have it for interfering several hours a day. So just some common obsessions. So contamination, one that we hear a lot about in the media, and we think of the traditional contamination obsessions, concerns about dirt, germs, spotty waste. But there can also be, there can be sort of mixtures between the types of obsessions. So someone could have a harm obsession about driving along and having an obsessive thought that they've just hit someone, and then they might engage in a cleaning ritual to try to dispel having that thought, or they might have a harm thought of hurting someone else and then be washing their hands to try to neutralize that harm thought that they've experienced, or that harm obsession. Symmetry as well, needing things to be just so or lined up perfectly. So, and maybe in terms of family, maybe wanting family members to do the same thing. So maybe when family comes home, having to align their shoes in a certain particular way, or that everything in the cupboards must be lined up perfectly and in order according to label and size and things like that. Aggressive or harm OCD. This is, it can be inadvertent harm, like having an obsessive thought that someone's house is going to get broken into. And so then they're wanting to check the locks, the windows, maybe, and get family to go around and check them several times at nighttime before going to sleep. It could be thoughts of deliberately harming someone. I remember working with someone years ago who was a grandmother, and she had her harm thought was that she would push her grandchild over a hill in the stroller when they were walking along, and absolutely that's something that she wouldn't do, and she was very repulsed by having that harm thought, and yet it would continue to come up, and resulting in her not wanting to have contact with her grandchild because she was concerned about the grandchild's safety. Yet it was really not something that she would act upon, but that was an obsessive thought that she was having. Sexual obsessions, another common one. Again, it could be something like that's just not consistent with someone's internal values and who they are as a person. So someone might have thoughts of violating a child, an adult, another person, and yet it doesn't represent at all who they are as a person, and they feel horrified by having these thoughts, and even sharing that can be quite difficult. Doubting obsessions, so just fear of not doing something right. Maybe I didn't turn off the stove right. Maybe we have a lot of people when there's a bit of perfectionism aligned with this one. They might be doing an assignment for school and take several hours to write a paragraph because they're going back, they're rechecking, they're seeing if they did it right, or they're sending an email and being concerned that the person on the receiving end isn't, that they didn't word it perfectly, or maybe there wasn't perfect spelling or grammar. Somatic obsessions as well, being concerned about contracting a serious illness, or maybe even a family member contracting an illness. So if a family member shares that they have a headache, then they might go right away to it's going to be a brain aneurysm. So worst case scenario. In terms of the compulsion, so this is what an individual with OCD will do to try to neutralize or reduce the distress of the obsessive thought. So again, we hear again on the media about the washing the hands for showering and cleaning rituals, but with someone with OCD, this can be extremely debilitating. People can spend like huge amounts of time in a shower, for example. They might be, as they're washing, just having their typical shower, they might be thinking that their hands got contaminated again. So as they're washing their different body parts, they may rewash their hands, redoing several parts over and over again, feeling that it's just not clean enough. Checking compulsions, very, very common. Again, we think of the usual ones, checking the stove, appliances, the locks, but it can also be checking, like, did I leave anything behind when I just left, or when I get out of the car, is everything locked, is everything secure? Or maybe we're getting out of the car and going somewhere, and then are we sure that we locked the car, because I want to make sure that someone isn't going to break in. Ordering compulsions as well, or rituals. So again, folding things. I mentioned that having cans all lined up at home. Everything has to be just right. We've had people ordering furniture, like getting up in the middle of the night and wanting to straighten the furniture in the facility. And again, it's that strong ritual and compulsion, not being able to have any ease until they do that. There can be counting compulsions as well, that I need to tap my foot a certain number of times, or I need to flick the light switch on and off 15 times if I'm having a thought that my family member may not be safe when they're driving home tonight. So I'm going to flick it on 15 times, and hopefully that will ensure that they're safe. So often there's not logic necessarily between the obsessions and the compulsions. Repeatedly doing things, so again, to cancel out a bad thought, flushing a toilet several times until it feels right. Transitioning, we see this a lot where people are transitioning just to get through an entranceway several times, just until they get that just right feeling. One way to think about just some common patterns of beliefs. So we see a lot of thinking styles that are connected to what people in OCD, some patterns that they may notice. So one is the overinflated sense of responsibility. I was giving an example this morning that if someone's working in an office and there's several coffee makers in their building, then that sense that I need to be the one to make sure I unplug every coffee machine when I leave work tonight. And if there's 10, that might take me a long time, because I want to make sure there's not a fire and that the whole building doesn't burn down. So that overinflated responsibility, exaggerated sense of threat, so tendency to overestimate the likelihood of danger, of something that will occur. Thought action fusion, this one again a very common one, just having a thought increases the chances or likelihood that it will come true. We see this with all different types of OCD. An example would be if someone has harm obsessions and they have thoughts that if I'm cutting up this apple, then I could, I'm having a thought that I could stab someone. And just because I'm having that thought is going to make it more likely that it will actually happen. And yet really just it's that thought action fusion. Just because we have these thoughts doesn't make it any more likely that it will happen. Perfectionism, we see that a lot in combination with OCD. So needing that, this idea that mistakes are unacceptable, not tolerable, having to do everything perfectly in our conversations and what we write and how we do things. And a real intolerance of uncertainty, very common across OCD, just that needing to have 100% certainty about everything in any given situation. Just a quick example, sort of how we sort of see it and how we help the individual with OCD to break it down. If someone's about to take out the garbage and the recycling, they might suddenly have an intrusive thought that there's contaminants on the garbage pail. That's dangerous. I'm going to get sick. My children will get sick. I'll bring it in the home when I come back in. I should have worn gloves, and people are, and then there might be another layer there that people think I'm an irresponsible parent because I've just made everyone sick or could make everyone sick in my household. So a tremendous amount of anxiety. You and I might have that same thought, or someone without OCD might have that same thought, but it's gone. It's just there for a second and it's gone, but it really sticks with someone with OCD. So they might engage in excessive cleaning. They might be changing their clothes that they use to take the garbage bin out and putting on different clothes when they come back in the house again. And washing their hands and over and over and over to prevent this spread of germs and to reduce that anxiety that's driving that behavior. Yes. Okay. So exposure and response prevention, a real cornerstone of OCD treatment. And so this is where we're really getting people to be exposed to their triggers, to their obsessive thoughts, and not engage in the ritual that they're used to doing to try to reduce the distress. So in our treatment program, ERP is very much planned with individuals, and we go about it at a pace that the person is ready to go about working through that. And so purposely refraining, the ritual prevention is purposely refraining from engaging in the compulsive behavior. So with the garbage pail example, then we would want that individual to be able to take the garbage out, not just have family do it so they can avoid the experience of the distress, but still take the garbage out, use their hands, not use gloves, and to come back into the house without changing their clothes and washing their hands several times, to experience that I'm going to be okay, my family members are going to be okay, and that I can actually tolerate this incredible distress that comes up when I try to do that. And we'd have them do that over and over again until it's less of a distressing experience. So in terms of family, OCD is very much, it just gets in there and very much is part of family life and part of relationships and friendships and probably more so than most mental health challenges. And so certainly when we look at OCD in our treatment program, we really want to involve the families or significant people that people identify as significant in their life. Because there's often ways that families or supports respond that seem to be very helpful, but end up actually accommodating the OCD. And like families are like mobiles, like the mobile, all parts are affected. And so when one family member has an illness, it's whether it's diabetes or OCD, everybody's impacted. The good news is that when we start to make change and when families start to change the response and the individuals working on making changes, there can be some lovely outcomes. We know in terms of effects on families that 88% of people who are living with a person with OCD report doing things like accommodating the OCD, and I'll show some examples of that in a moment. It might be engaging in rituals, so maybe they're going around at night checking all the locks just so that person can get to bed earlier, or so that you can maybe have a conversation together versus spending so much time checking and rechecking things together. And we really emphasize we never want family to feel guilty about accommodating OCD. It's the natural response that we expect people to do because they're trying to reduce the distress of the person with OCD. Just some common reactions of family members. And sometimes there can be some denial about what's going on, and maybe like even saying things like, why do you make such a fuss? Let that person continue counting and rereading their emails. At least they're not having trouble with drugs and alcohol. So sometimes there can be a bit of denial about what's going on, or it can take a while to even understand what it is that's taking place. Rejection. And again, I think this comes because OCD can be very impactful and frustrating for everyone. So sometimes people will give a response, or family or friends, that might feel sort of rejecting for the person. But again, it's just, maybe it's come from a place of frustration. So just cut out the hand washing. Look at your hands. They're red, they're chapped. It's not normal. I can't keep living like this. You're asking everybody who comes in to wash their hands. But recognizing how that feels for the person. They're not doing it on purpose. It's their OCD that's really driving those obsessions and rituals. And then accommodation, again, when family members might be participating in some of the rituals. I'll show some examples of that. And we do know that different family members react differently and have different responses with OCD. So just some examples of family accommodation. It could be that someone who's doing several loads of laundry, maybe they're even re-washing the same clothes more than once because their OCD is telling them that we must do that. Family might be accommodating that by buying the extra laundry detergent and the soap. Maybe they're even agreeing to wash clothes, help them wash the clothes by doing the loads a couple of times. Opening public doors if someone's worried about touching the doors from a contamination point of view. So it reduces the distress, but it keeps the OCD very much going. Retracing driving routes. So you're driving to work with someone and the person has OCD. They just have this obsessive thought that they've hit someone, and you agree to turn the car around and retrace the driving path to ensure that did we indeed hit someone. Also, just even personally, OCD can really take over. So families and supports often stop doing what they need to do for their own self-care. And that's something that we're always talking about, to try to encourage and empower families to get back to doing some of those things and not letting OCD completely take over. People will avoid topics, colors. If someone has harm OCD and they don't want to hear the news where there might be harm being talked about, then the person might accommodate that by, we won't watch that on the news tonight, and yet we might be interested in being able to watch the news. So accommodation is really making arrangements for OCD to stay in the family. And when we're working with individuals, we want to help them change that response, or the family members change that response. So if you're out for a walk and maybe someone has an obsessive thought about dog feces, and so they're trying to ensure that we don't go anywhere near a park, or they might see a mark on the sidewalk and want you to switch to the other side of the street because they might think that it's dog feces. And so the family does that. They go out for the walk, they avoid the park, maybe they even bring Lysol along to spray on the sidewalk if they happen to see a mark, just to reduce the distress of the person. The problem with that is, again, it will reduce the distress of the person, maybe even your own distress, so you can keep going on the walk, but the OCD gets fed and made stronger. And so what we want to do instead is sort of collaborate and negotiate how we're going to, this is something that I don't want to keep doing. I want to be able to go out for a walk and do some more freely. I recognize that you have these obsessive thoughts about the dog feces, and you want to avoid anything that could be related. But let's agree today, can we go for the walk? Can we sort of go near the park? We won't go right in the park, or maybe we'll walk by the dog park and not go right in the dog park today. And still sort of work up toward that. And so that OCD starts to be less welcome, and that we're acknowledging that, yes, this is really distressful and it's important because probably the person also wants to be able to walk around more freely. Just some final tips. I'm not sure how the time is. 5 minutes? Okay. So some final tips. Again, just keeping in mind of I think that, it's the person is still the person, and their OCD is often what's driving these difficult obsessions and responses and requests that they're making of you. So just a couple of examples. If we see a bread knife, for that person with OCD, they might see that bread knife as a reminder that they could hurt someone, and that they have this perception that they might be a serial killer. or they see a mark on the wall and it's just, it's so hard to tolerate that. I'm having this urge to start cleaning the entire wall. So recognizing what they see and what we see are two different things, and that it can be quite hard to let go of some of those thoughts. In terms of just general tips, learning as much as you can about symptoms and treatments for OCD. We have the pamphlet or the booklet that Dr. Richter talked about in terms of, that's a patient and family handbook about OCD. So we have those available and on our website. Supporting your loved one in getting the treatment they need from pharmacologically and the actual treatment program. Trying to see your relatives' behaviors as symptoms and not character flaws. So important. There's still that person who's a lovely spouse, sibling, friend, and have all the wonderful characteristics that make up who they are. Working on not participating in your relatives' rituals. If it's been going on for a while, we can't just stop cold turkey, but doing so gradually. And if they're involved in treatment, or even if they're not, figuring out how can we reduce some of these ways of responding or providing reassurance or helping you with your rituals to, again, break that hold that OCD has in the home. Try to keep family routine normal. So again, not allowing it to take over your life or the life of the individual with OCD. So trying them to still do the things that are value in their life. And we know that OCD is going to come along with them as they do that, but still being able to try that out and work with the challenges that it brings. Just being able to recognize signals if your loved one or friend is having trouble with OCD, and so being aware of what those common flags are, and maybe they've done well for a while, and then some of these symptoms have come back. That repetition of doing things over and over, that constant need, those reassurance questions coming: is this safe? Am I going to get sick from touching that or eating this? Simple tasks taking longer than usual. Maybe the person who stopped doing checking in the morning is suddenly doing a whole lot of checking, and so we just want to be mindful of what those signs are. And lastly, just really keeping communication open and positive with the individual, stating what you want to have happen, and you know, the pace at which we can break it down rather than criticizing them for their rituals, and recognizing small accomplishments. It's a tough illness, and there's like those small steps along the way. We were talking earlier this morning that we might not even realize the progress that's being made, but the individual themselves know that they're doing less mental rituals or they're doing less checking. Might not be so apparent to us, but it's important to be able to really acknowledge that. Okay. All right.
Thank you.
I know there's a few more slides which you can make available, but I think just in terms of time, maybe to continue with the panel discussion.
Thank you, Sandra. Do you want to take a couple? Thank you so much. So what we thought we were going to do now is open it up to a panel discussion rather than just taking questions just from Sandra. I just want to introduce our panelists briefly. We're delighted to have with us today some other staff from our intensive treatment program. So Dr. Marlene Taube-Schiff is a clinical psychologist who is heading up our intensive program, and she's been working in the field of mood and anxiety for about 15 years now, authored about 20 papers, and we're really pleased to have her with us, as well as Eliza Ladak, who is an occupational therapist who's been working also in mental health for about 5 years now, instrumental in, again, helping set up our program, and also works and teaches students at McMaster University in the occupational therapy program. So we're delighted to have everybody here with us. And why don't we open it up for questions? Maybe what we'll do is remind you folks to turn on your mics, or let me... sorry, give me a moment, people, while I just get our bigger screen up for people in the other venues. There we go. So why don't people maybe stand up if they have a question? And how about if we do it that way? Yes, please.
Hi, Jerry. I'm just wondering if there's some kind of chemical imbalance in the brain. But what would trigger to go from hardly anything to blow up overnight without any obvious triggers?
So that's a really good question. Maybe I'll just repeat them quickly since we don't have mics in the audience. Jerry's question was about how he understands that OCD may have a biological basis, but why does it suddenly sometimes just seem to erupt almost overnight without clear triggers? And I wish I had as good an answer as that question, Jerry, because in some ways we don't really understand why OCD announces when it does. Certainly we know it is biologically based. There are genetic roots, there are neurochemical roots, so in terms of neurotransmitter changes. And actually, increasingly these days, we often refer to illnesses in the brain as disorders of neurocircuitry. So people may have heard terms like circuit disorders in the brain. And I think as our evolution of, as we evolve in our understanding of the nature of OCD, we're recognizing that there's a circuit underlying OCD. One theory is that in some ways it may be tied to maturation in general. OCD tends to start becoming substantially worse in males, usually in the early to mid-teens, and another bump in the 20s. For most girls, it's late teens to early 20s. And it may just be as our brain is maturing that it kind of unveils some of these symptoms. For some individuals, there can be triggers, but you're absolutely right to point out that not always. But I wish I had a better answer, except that we think it's there, the predisposition is there, and at some point, stress adds up in other events, and it shows itself. Anybody? Good. Next question. Anybody? Yes, please. Why don't you stand up?
This morning, Dr. Marlene said that.
Can you speak louder, please?
This morning, Dr. Marlene said that the program will be secured for the next 4 years, regardless of any new provincial leadership. But I was just wondering, is there anything from your opinion that would be best for the Thompson Center in terms of like the next election and how you could get more? Because like I know that what you have, like the 3 beds that you have now, like although that'll be secure for 4 years, that's not enough.
Thank you, Stephanie. I don't want to get into politics here. I think far be it for me to comment about voting in the next election. But Stephanie's point, just to summarize, was quite accurate, which is that that gift that has enabled us to launch all these initiatives does run out in about 4 years. We do have some provincial funding, and that has helped support the launch of our intensive treatment program and covers most of it, although we would love to see it grow. So her question is what you can do to help. And I think, in a general way, writing to your MPP or your MP is one great thing people can do. Take a look at the platforms for healthcare of the various parties. We're probably going to have some fundraising events in the upcoming year. There was an OCD walk by the waterfront last year that was really quite wonderful. For some of us who are here, we have t-shirts to prove it, and there may be others. So if you're interested, again, if you follow my currently somewhat sleepy Twitter account or look on our website, we will try and make sure we get those things up. And thank you for the question. Yes, sir, at the back.
I had a question about diagnosis. I'm wondering if you can comment on similarities between unwanted intrusive thoughts and a psychosis such as hearing voices.
So sorry, the question was about sort of the differential diagnosis between those elements. Can you, okay. So the idea of, can you just repeat the question once more?
OCD versus psychosis,
Just
I think,
OCD
in hearing
versus
voices.
Psychosis? Okay. So, I mean, in terms of the thoughts that we would experience in OCD, although they tend to be intrusive and unwanted, they would have a different feel than if someone is hearing command voices that might be telling them to do things, or hearing voices that don't feel like their own sort of internal dialogue that's speaking to them. So it has a different quality in that sense for sure. So that would be a big piece already. With OCD, there are times that people can have what we think of as very almost absent insight into the way their OCD is functional, and it can sort of at times take on what we see as almost a delusional quality, in the sense that there's an inability to recognize that they have OCD, and that the unwanted thoughts that they have is part of their OCD. More often than not, there is some kind of insight that's present, and individuals will recognize that it is their OCD, they'll recognize that it is intrusive thoughts, but they still feel such a strong urge to engage in the ritual to try to get some of that relief. So that has a very different feel than an individual that's really hearing voices that feel very detached from reality, very outside of themselves, and maybe telling them to do things that feel extremely aversive. I don't know if that's helpful. Yeah, okay.
I think it also highlights sometimes the importance of getting a proper diagnosis from a healthcare professional just to help sort out issues like that. There was a gentleman here who wanted to ask.
He's not functional, he doesn't live with us. He has, his OCD is basically, he spends more, he spends so much money that he cannot even afford food. So we're in a situation where if we don't feed him, he will die. So I just wanted to get some additional tips. He's also extremely stubborn and he won't listen to anything we say.
So the question was around a family member, sadly, with very severe OCD not living with you, who, as part of his OCD, spends excessive funds to the point that he won't even budget for his food and is requiring the family's help to get by. Does anybody want to answer briefly? Just have to turn that on.
Sure. Yeah, it's a tricky one because it makes sense that you obviously want to see him eat. I guess I don't know if the spending money, if it's related to a particular obsession that he has or a ritual that he likes electronics. Okay, so he's spending a lot of time buying electronics, and I don't know if there's an obsessive nature about having the electronics. But I mean, I guess from an so it sounds like family's helping out in terms of like ensuring he gets food to eat. And I guess in some way that might be maintaining the OCD a little bit. I'd have to understand a little bit more about his nature of his OCD. But maybe it would be helping out a bit less if that was going to be a motivating factor where he could spend his money more carefully and to reserve some for food. But I think being very transparent and having that discussion with him, and if it's feeling like it's too hard for a family to keep doing that and probably not good for the supporting the OCD, then how do we begin to get him to participate more in using some of that funding for his care, his living expenses?
I think one of the challenges in a situation like that is working with the individual to help them to see the dimensions of the problem. And often one of the toughest situations I see for family members is when their loved one doesn't yet recognize the OCD for what it is and isn't accepting help. And unfortunately, it is a really tough situation, and we don't have easy answers here because the kinds of treatments that we're talking about here today, or working with the family, as Sandra's addressing, really rely on individuals being part of the solution. They have to be part of the team. They're being taught skills that they have to then work at gaining. And so sometimes it's unfortunately a very tough wait for family members to come to that point of seeing it. Question in the rear there. Yeah. Pink, yeah.
Two questions. The first is when you had ERP,
yes.
I didn't get the two sentences under RP. I wonder if you could just read them again. And my second question is OCD seen in the third world?
So just to reiterate the question was in the slide that talked about E and RP, what else was in there, and do we see OCD in the third world? Is that correct?
So I can't remember the words exactly, but it would have been, the RP is the ritual prevention. So the exposure is what we're asking the person to expose themselves to in terms of the trigger, the obsessive thought, the obsessive image, and then to refrain from doing the ritual that they would typically do in response to that obsessive thought. So for example, if someone has contamination OCD and they're wanting to, and they've just been at school or something like that, and they've touched the public washrooms or the doorways, and then their ritual that they're wanting to do is to come home and completely shower, change their clothes, wash their hands several times. Then the ritual prevention would be try to refrain from doing that. but in a paced, gradual way, and to tolerate that distress that comes.
And in terms of OCD in the third world, absolutely, OCD has been seen worldwide in studies that do look at it. So the data is a bit limited for third world, but there is some data suggesting it is an illness of equal opportunity. It affects everybody around the globe. I think there was a lady right there, yes.
My name's Maureen. I was wondering about, I know we did talk a little bit about funding, but I'm from Saga, and I'm thinking about, is it Sunnybrook the only place in Ontario for people, I would imagine that people coming from Peel and such come into Toronto, and then having, I'm not sure where they stay or whatever, what is, can you talk about that?
So I just want to point out that any family health care provider, family physician, nurse practitioner, can in fact initiate what we call first-line medications for OCD. So that normally is available pretty well anywhere around the province and should be. When it comes to more specialized care like cognitive behavioral therapy, there's certainly lots of excellent private providers. In terms of the public services, it is a bit limited, and outside of our program, there's a fabulous service in Hamilton, the Anxiety Research and Treatment Center, and CAMH also has services. And there are certainly smaller degrees of services at many local hospitals, and I can't speak to all of them, but it's a matter of looking one by one. The services that we offer uniquely here in Toronto are those focusing on more severe or treatment-resistant illness. So when people have failed multiple types of treatment, multiple courses of medication, perhaps a good round of cognitive behavioral therapy, like you heard Sandra describe, that's when we might be able to step in with our intensive treatment program. And we do have a small number of beds for patients who stay on site in residential care, or the ability to see patients as day patients where they would have to make their own arrangements for a place to stay at night. Thank you for the question. Sir at the back.
My name is Bruce, and we're glad to be here. This is about medication and dosage, and I was attending the mood disorder place in July when you addressed it that evening, and we were talking about levels of dose. You mentioned a couple of times maximum dose of the main drug is indicated or recommended. Ironically, a couple of weeks ago, I was sitting with our GP, and he was looking up the dose of this particular drug our daughter has been taking, and he said, when we go above 20 milligrams, red flags start flying. So can we reconcile this seeming contradiction?
Yeah, so the question was around, seeming contradictions around what experts like myself would say is the best dose to aim for in OCD compared to many physicians' comfort level and what is out there in terms of guidelines. So I don't wish to get into a lot of detail, but there are a couple of common medications, namely Cipralex or escitalopram, which is probably the one you're talking about, and Celexa, where we certainly know that at higher doses they can have a very small impact for an average person in slowing heart conduction. And for most people with healthy hearts, it's very much a non-issue. But of course, if somebody were to have some irregularity in their heart already, it would be something we'd need to watch out for. And some people will have a bigger effect on their heart conduction than others. So normally we recommend simply monitoring, because the best evidence in OCD is that we nonetheless go higher. Information for stuff like that for your treatment providers, I'm pleased to say, is now up on our website. So if you direct your healthcare providers to the clinician resources on our website tab, we actually have a chapter that goes through the rationale for how best to prescribe medications for OCD, along with some other resources. And I'm also really excited to again share that with ECHO Ontario, which is a fairly new initiative the government has embarked on to try and reach healthcare providers across the province and give them more knowledge for complex disorders, is launching an OCD ECHO in partnership with our team. And family doctors are welcome to sign up. Sign up is now open. Information can be found on our website, and we have some sheets out in the hall. Thank you. Sir.
Can you qualify the difference between OCD and OCPD and the treatment variations between the two?
Yeah, sure. So OCPD is more what we think of along the lines of what we consider a personality disorder, which means that the types of thoughts that an individual can get with OCPD are more in terms of they're comfortable to themselves. So we talk about OCD as the individual having thoughts. Sandra described this as this idea of internal discomfort. So having thoughts that are intrusive and unwanted and cause the individual a great deal of distress. Whereas in OCPD, more of a personality disorder, the thoughts may actually feel quite okay with them, and they might not have any rituals in response to those types of thoughts, and they may not be in any kind of a hurry necessarily to get treatment for what they experience. Often with personality disorders of any sort, we see discomfort in the environment that the individual lives in, so with family members, and that might bring the person then into treatment. Often people call OCPD perfectionism, but sort of almost like a pathological type of perfectionism. Individuals with OCPD may or may not experience OCD as well. They don't necessarily do that. Treatment can also involve a similar kind of cognitive behavioral therapy approach. It can sometimes be a little bit more difficult to engage the individual with OCPD because of the fact that they're not experiencing necessarily the same amount of distress that we would see in OCD or depression or any other type of anxiety disorder that can cause more distress in that sense.
Thank you. Maybe at the back, perhaps.
Two things. One, I know a little girl who will line up the shoe or the shoes of the guests coming to the home. And the family thinks it's really cute. You know, you say, take your shoes off, and then she lines them up. And I'm wondering if this is a red flag, perhaps, and what I could say to the mother, if that's something I shouldn't say. And I guess the second thing is, I know someone who is a student, and I will go to the library instead of taking maybe 5 textbooks to do research, will take out, let's say, 15 textbooks. And I'm wondering if there's something that I could do, perhaps, in
So there were 2 parts to the question. One was about normality, or is it pathology, of a young child who's lining up shoes and doing other things around the house. And then the other was around somebody who does excessive research as part of their studies. So maybe I'll answer the first one. I think it's important to recognize that children go through developmental phases. And so it can be a very normal part of children's early years to have little behaviors or desire for sameness and familiarity. And sometimes that can look a bit like OCD. And I'm sure anybody here who has young children, I've had 4, although they're not so young anymore, and one child in particular had to have, still does at age 12, her entire family of stuffies on the bed, for example, and they all need to be there, right? So these kinds of behaviors are quite normal. I think what we look at there is the degree of distress if it can't happen the way they like it to happen, and whether it's getting in the way of functioning. And usually when this is developmentally appropriate, it's just a passing phase. It's not really getting in the way of function. The nighttime ritual may take a few minutes, but it's not catastrophic, generally speaking, if it can't happen. And then, of course, time will also tell. So it is important, I think, to have a healthy ability to step back and say, sometimes these things are quite normal, and just keep your eyes open. Now, about excessive research, I'm wondering whether somebody else in the panel would like to talk to that one. Anybody?
Okay. I guess, again, it depends. Is it a problem? Because it may certainly not be an issue. So again, I would come to what is the function of the behavior. So in this case, excessive research. OCD could be driving it if the person may be experiencing a lot of doubt and uncertainty. Am I doing this right? Am I obtaining enough research to write my paper? What if I make a mistake? And then the behavior, excessive research might be, okay, I need to get a a lot of information. I need to check, I need to consult all these sources in order to do a good job or to get it right or to get it perfect. At the same time, that may not be the case. I know, when I was a student throughout my studies, I would go to the library and maybe take out a lot of research to complete an assignment, and there might be some anxiety and stress associated with that, which might be typical for a student, but it can certainly be beyond that. So I'm having an understanding around that could help see whether it falls in the OCD realm or not.
Yeah, I want to point out that Eliza brings an occupational therapy lens to all of this work. So she works with individuals in our program when it is about looking at necessary daily tasks in their lives and how to accomplish them. And I just want to point out again that, again, one of the other things we look at is degree of dysfunction, which Eliza was definitely getting at. So if the student is still able to accomplish her work and in fact does a very good job on her work without the price being exorbitant, we might say that's pretty functional for them if they have high standards. When it reaches the point, however, where they can't possibly do it and they're doing so much research perhaps that they never get to the finished product, that's when we also begin to think that there's something else driving it. Question at the back.
Hi, my name's Vera. I was wondering if you could comment on the most common medications used to treat OCD.
Sure. So the question was the most common medications used to treat OCD. So the class of drugs that we call the first-line drugs, meaning the strongest evidence, the best balance between effectiveness and side effects, are the selective serotonin reuptake inhibitors, or SSRIs as they're known. I believe that we have links on our website to other educational events we've done in the last year or two. And I believe, I'm pretty certain we still have a live link through Sunnybrook on our website, or through the speakers series at Sunnybrook as well, to a talk on drug therapy for OCD. And by the way, I was actually thinking about that in connection with one of the other questions, which is that this part of today's event will also be linked on our website so people can see these presentations again. The specific drugs in that class include a number of agents. So if I use the trade names because they are more familiar to people, it's drugs like Cipralex, Celexa, Zoloft, Prozac, Paxil, and Luvox. And all of those medications have good evidence for their helpfulness. There are other drugs that we use, but either the degree of evidence is a bit lower or the side effect rates may be a little higher, which is why we usually call them second-line options. Question at the back, sir. Yeah.
We're a family that's been dealing with OCD for about 2 years now. We started at 6 kids. They had an excellent work. But our son is now 18, and so we're looking for, since we know that OCD is a lifelong, possibly lifelong, we're looking for what kind of things can you do, what kind of approach should we take to continue to treat it for our son for the rest of his life.
So the question is about long-term care. I'm not sure if you mean specifically through our program or you mean in the community more broadly. Our program is typically restricted to an episode of care for those with more severe illness. So the idea here is that unfortunately we are it for the province. We're one of the major programs, and we can't take everybody on and treat them indefinitely. So we usually try to see people for a consultation as much as possible and then help them link or suggest that they find links to local healthcare providers. What we are doing, as I mentioned before, is working on a number of educational strategies to help build that level of comfort out in the community. We've had intensive training program open to physicians. We've offered a behavior therapy training institute last year for any mental health providers, and we'll probably be doing again an intensive training for healthcare providers sometime in 2019 again, I would expect, although we don't yet have dates set. So I think the important thing is to find a healthcare provider in the community who may or may not have OCD specific expertise, but then to maybe link up with a service like ours for consultations where we can at least set directions on steps to go. There are also there are some providers out there who do CBT. It can be challenging. I think one exciting thing that's happening right now, and this is part of the changes that was alluded to by an earlier question politically, is that Ontario is launching initiatives now to make brief psychotherapies more broadly available and covered so that people don't have to pay privately. And it's just in the early rollout phase, but I think by next year it should be beginning to make an impact. And I would certainly hope that CBT will be much more broadly available across the province within the next year or so. But it's a tough situation. Maybe a question up here.
Why is it that there's not that many people that have the OCD expertise, and is there a way to try and encourage people that are studying to go into mental health to focus on that?
A question after my own heart. Why do we not have more experts around people who take a real interest in OCD and have studied it, and how can we encourage more? So I wish I had a great answer to that. I don't. I mean, one thing I will say, though, is that in mental health, it's gone through major waves. If you think about, for those of us old enough to remember the 70s, any mental illness was definitely perceived as major stigma. And I'm not saying it isn't stigmatizing anymore, but I think we've seen a lot of gains that way. When we got to the 80s, depression suddenly became the buzzword, and it was actually kind of okay to acknowledge depression. And I would say in the 90s and even more in the 2000s, we're now seeing some of that happen around anxiety and beginning to happen around OCD. So I think it's a slow sea change. In terms of what people can do, I think encouraging your healthcare providers, being open about it, and this is a tough one. I should say, I say that and then I think about it and want to step back and eat my own words, because I don't have to live with it. I'm in the fortunate position of being identified as an expert. But I think few things are more powerful than individuals who stand up and are comfortable sharing their story. And I think that really moves the conversation forward. I know there's some material videotaped on our website. An interview the day Kathleen Wing was here with a member of our, somebody who's in our program, other interviews on our website. And I'm so grateful to people like that. I won't name them today, but they know who they are. I think we're trying also to do our best by making sure that it's built into curriculum, not so much at the medical school level, but certainly at the psychiatry level. And we're trying to do our bit in our program. We've had, at this point, 8 psychology graduate students rotate through in the short year we've been open. I better wrap up. And 1 OT student and 1 psychiatry training, and we're opening our doors to more, we hope. So we're trying. Maybe I'll take one last question, and then I'll remind people that we also have an email site. So if people want to email questions, I'd encourage you to write them down, send them to us at thompsoncentereducation@sunnybrook.ca. And we will, if you're registered and we have your email, we will be pushing out something in the next week or 2 with answers to the questions I can't get to.
People are also welcome to put additional questions on the evaluation forms that they have, and then we'll try to answer them in some kind of a summary sheet afterwards. So that's another option for you as well.
Okay, maybe.
Even though there's still a few hands.
I see quite a few. I'm going to take one last hand over here.
I know we talked about treatment, and I'm just wondering what other kinds of treatment, like talking about work-related programs or programs that are rehabilitation in focus, because we talk about getting medication or CBT, but there's other aspects of reintegration back to the community are pretty significant based on, person-led symptoms and how to cope with employment situations.
Yeah, that's a great question. Thanks. It's about, are there other programs that look at rehabilitation beyond the initial treatments? I don't know, does anybody want to speak to that one?
I think in our program, at least, we approach care holistically. So as the OCD takes up less time and space in the person's life, we really start to explore, what's meaningful to them, what are their values, and how can we now work with you to get back to whatever it is in life that we want to do or need to do or are expected to do through life skills training, vocational support. Sandra does a lot of work around discharge planning and transitioning back to the community.
The peer support piece. I wanted to add that in because it spoke to a question before, which was in terms of kind of lifelong maintenance. How can people look into that? And I can't list them all. I don't know if you know them kind of off the top of your head, but there are a network of peer support groups throughout Toronto and Ontario that can be a really wonderful avenue to maintaining wellness, asking others who have gone through this, kind of what the avenues they used, how they got back on their feet, and can also help if you need to then get reconnected to healthcare providers. It can be another avenue. So
we have some tables, I think, as well,
Yeah,
talking
they're
from some of
outside.
the, like the Toronto West OCD support group and Mood Disorders Association and Christina. Yes. Did you want to share for a moment?
I can say, my name is Christine. I'm with the Toronto West OCD group. We meet the third Thursday of every month from September to June. We're located at 50 First Street West. That's Dundas West subway station. And there's free parking after 6 p.m. Friends, family, youth. There's supporters to come. We have at the Sunnybrook table, we have brochures. I'll be there if you want to speak to me. We've been operating for almost 30 years. So there's a bunch of us here, and we'd love to be here. Family, friends, supporters, you're all welcome. It's free. You don't have to register. And thank you.
Thanks, Christine. Can I just want to comment that thank you, Christine, and I'm so glad your group is here and people can meet with them. There are a number of other groups as well. So the Mood Disorders Association of Ontario does have a group for support, both for peer support for OCD, for hoarding, and for family members. And there are a few others around the city. We try to maintain links on our website so people can find out what's out there. And if we're missing somebody and we're out of date, please do let us know. I think there's always a need for more, but at least there's a lot more than there was 10 years ago. Sorry, did you want to?
No, I'm Noah, and I run the peer support groups at the NPAO.
Hi, Noah. Great to meet you.
So the first Thursday, and I can maybe send it through an email, but yeah, we're last minute comes we didn't prepare. But the first Thursday of every month is for individuals, and the third Thursday of every month is for family members and loved ones. So there's two groups that are running twice, bi-weekly.
Thank you. I think for the sake of giving people some time, we are running behind, so I'm going to close it there. I want to thank you for the great questions. I'm going to suggest we keep our break to 15 minutes, and we'll be starting right around 22 then for the workshop and inviting Dr. Breacher, okay, at that time. Thank you all.